Hello, I'm Neka Nwokolo, Senior Global Medical Director at ViiV Healthcare, and today I'm going to be speaking to Dr. Vanessa Appiah, Consultant Physician in Genitourinary and HIV Medicine and Research Lead for Sexual Health at Barts Health NHS Trust in London. And we're going to be discussing the current state of health inequalities in the UK, and this is on the back of a report called Achieving Health Equity, a Roadmap to Eliminating Disparities, which was a report conducted by The Economist Impact and sponsored by ViiV Healthcare. So, hi, Vanessa.
Hi, Neka.
I'm going to start with just a question about you. Can you tell us a little bit about your job as an HIV physician and research lead at Barts? And also, if you could say something about what led to your interest in trying to understand health disparities.
Okay. No, thank you. So, yes, I'm a consultant in sexual health and HIV. And when you work in that specialty, you can't not be aware of inequalities because sexual health and HIV are really rooted in inequality from their occurrence. But within sexual health, a lot of my work has been about supporting engagement and access for particularly marginalized groups, for everyone, but often those that don't engage with the services are those that are more marginalized. So those that have added vulnerabilities, but also migrants. Racially minoritized groups, so people that have had difficulty with education and housing and things like that. So all of those things that can impact someone's engagement with care, with sexual health. And then within HIV specifically, I lead on a clinic which supports people who have previously disengaged from care. So really fortunate to work with a number of fantastic colleagues to run kind of a one-stop shop clinic that manages the medical side of care, but also holistically. So we look at we have a social worker, a psychologist, a peer mentor that really thinks about what are the things that limit someone to optimize their engagement in care. And I think in response to how I've gotten into this work, so as my work has evolved, have really focused on the intersection between race, ethnicity, gender, and health. And I think it comes from who I am and how I've grown up. You know, I'm a second generation migrant. My family is originally from Ghana. I've born and raised in East London and have seen firsthand how different opportunities can really impact someone's health outcomes. So yes, that's how I come into this work.
Thanks very much. So the Economist report did look specifically at HIV, sexually transmitted infections, and mental health. But speaking specifically about HIV, which is obviously your area of interest, what do you think are the most important factors that contribute to health disparities and reduced quality of life for people living with HIV?
So I think there are a number of factors, and one of the things I think it always circles back to is stigma. So, you know, when someone is exposed to HIV, acquires HIV, has a diagnosis, and then engages with care, there's lots of I always say decision points and key points within that journey. And all of those are impacted by stigma and discrimination on many, many different levels. So people, by virtue of where they live and who they are impacted by discrimination, and that then impacts their opportunities and puts them at more at risk of being vulnerable and being exposed to HIV. And then I think that stigma stops people engaging and testing for HIV, and then they are more likely to be diagnosed late, and then that can also then impact their health outcomes, but also how they engage with care longer term. So I think that when we look at the disparities across gender, when we look at disparities across ethnicity, when we look at disparities across sexuality, I think stigma is key to driving it. And stigma operates at many different levels. So it operates at a structural level, when you're thinking of structural racism and structural inequalities there, but then also interpersonal stigma, and then self-stigma. So people's perceptions of themselves and negative perceptions can also impact how they engage with health and experience health and well-being as well. But then I think, as I said, particularly with HIV, is that many groups are marginalized or experience differing opportunities to others, and that then impacts their health outcomes. So socioeconomic class, socioeconomic status, class, poverty, austerity all feeds into that, housing, education. So if you're living with HIV and you're on effective treatment, but you're living in a house that is damp, and you can't hide, you're not able to disclose to family members or people in the house, but you've got nowhere to put your medication safely, all of those impact how you experience health and how you manage your HIV. So I think all those layers are really, really important in determining people's health outcomes.
So people often speak about the effect that the COVID-19 pandemic has had on health disparities. Do you agree that there's been such an effect? And if you agree, why do you think this is, that COVID-19 has actually impacted perhaps more adversely than we might have thought on health disparities?
No, thank you. So first of all, I think it's about where we started. So we started on very unequal footing for many people in society. And then you brought this almost, catastrophic pandemic on top of that. And then people experience it differently. And so, it's interesting because it's been said again and again, pushing away that comment of, COVID has been the great leveler, and then everyone rebutting and saying, absolutely not. It hasn't been the great leveler. It's just exacerbated inequalities that have been there throughout time. And I think that it is very clear that different people experience health and have different opportunities for health. And that has been clear for many, many years. You've got a whole body of literature that will testify to that. And then on top of that, you bring COVID in. And then COVID, I always say that it's COVID relies on individual behavior, group behavior, and then there's a certain privilege of prevention as well. So we said that for COVID to prevent COVID, people had to socially distance, stay at home, wear masks, so many different things, and have access to the right information. But there's a certain privilege in that. So if you have a role that you are a frontline worker, or you're on a 0 hours contract, so you have to be out in the forefront. If you don't have that, you won't get paid. You don't have any other access for funding. If you don't have heating and electricity in your house, you don't have access to Wi-Fi. How are you then supposed to have that option of prevention? You simply don't. And I think that you build all of that on top of people of differing ethnicities, age groups, genders, class, that have different underlying health conditions, different social circumstances. All of those have really impacted people's experience of COVID. And I think that we did some work in East London looking at COVID outcomes across people hospitalised in East London. And it was really clear. So you could account for socioeconomic status, you could account for gender, you could account for age. But what was striking is that those of Asian ethnicity and Black ethnicity had poorer outcomes with regards to COVID.
So what sorts of partnerships do you think should be being forged to try to achieve, this goal of ending health disparity? And do you think it is actually achievable?
So I'm ever an optimist. So I think it is achievable. I think it's, but the key thing is being relentless about it and doing it in collaboration, because the work is tiring, and so it can't be the same people doing all the work, like in anything. So it's got to be collaborative and like-minded people working together and drawing those that aren't like-minded into the whole arena as well. But I think what is really key is recognizing that everyone has a part to play in achieving it. And I think that's one of the things that was highlighted in the report about thinking, you know, it is policymakers, it is government, but it's also it's crucially community groups, it's healthcare professionals, it's academics, it's other people in the health and social care economy, you know. So everyone has a part to play in supporting people's better understanding of health, engagement of health, and really that whole, you know, the whole concept of health literacy. So knowing how to prevent, knowing how to engage, and knowing how to manage conditions, all of that requires everyone in the system to be involved. And I think that, you know, something beautiful that happened in COVID was the spotlight on community. And, you know, when everything was going wrong, it was people on the ground doing the food banks, calling people and making sure they were okay, letting local authorities know that there are a group of pensioners over there that rarely engage with anyone that needs support. So those conversations were invaluable. And I think that they've been pivotal in vaccine engagement, etc. And they will be pivotal in wider health equity. And the other thing is, I think that what's been really important is really speaking to communities and asking them, because I think a lot of data and insights can focus on numbers, which is fine. You know, we need numbers, we need that context, but you also need the social context in which people live. You need to understand people's lived experiences, and then you understand how is that determining their health behavior. So but I think that being the optimist is that understanding of mixed method approaches and working with communities, I think, has come up to the forefront, and I just hope it continues, definitely.
And as you say, there have been examples of how that has really been successful.
Mm-hmm.
So one final question then, and this is to ask you what healthcare providers can do. You know, we are both healthcare providers. So what can healthcare providers specifically do to make a more meaningful impact and improve health equity?
So again, it's such an important question, because I think that first of all, it's for healthcare professionals to recognize their power, and to recognize that you are far more powerful than the patients that we serve and the communities that we serve. And with that power comes a lot of privilege, and it comes a lot of responsibility as well. And so it's about harnessing that in the right way and in the most respectful way. I think also, as healthcare professionals, we function in different ways through health. So one of the things is just educating ourselves. I think as healthcare professionals, also remembering that we work with many people in their diversity, be it ethnicity, race, be it gender, be it differing abilities, neurodiversity, physical disabilities. And so for us to achieve equity, it's about also advocating for our colleagues as well, and the wider MDT, and being really focused on that. So you can have all the education and training, but it is about how you are as a colleague, and minimizing bias within the workplace for each other. And then I think we have responsibilities of wherever we work over measuring equity and raising that conversation, and having a lens of inclusion, and, you know, having a lens of recognizing that people have different lived experiences, live at different intersections of life, and so they have different levels, systems of oppression that could be working within their life. So we need to see them as an individual and have that tailored view within that. And then I think lastly, just being advocates, speaking out when things are wrong, or feel uncomfortable, but facilitating, psychologically safe spaces for people to do that.
Thank you very much, Vanessa. A lot of food for thought, but I think, like you, there is optimism that we can get it right.
Great. Thank you so much.